first thing we want to do is just to remind you of the equation, I suppose, or the what is value-based healthcare all about. And we put this up as our touchstone every time, no matter who we're talking to, as much as to remind ourselves about what it's all about. It's about the outcomes that matter, health outcomes that matter to our patients or clients, and it's about the cost of what it costs to deliver those outcomes. And what we want to do is to make sure that everybody within our organisation is constantly thinking that, no matter who they are, whether they're a clinician or whether they're the person who's cleaning the floor or anything, that they are constantly turning around and going, is this adding value? Is this helping to either improve a health outcome, or is it actually trying to reduce costs, or is it hopefully doing both, which would be fabulous? So this is our aim, to try and deliver on this. We constantly also try and look at what is the value agenda for us at Dental Health Services Victoria, and it wouldn't matter what organisation you were, you could probably put this up. It's pretty consistent no matter who you would be, but what we're obviously trying to do is improve the best outcomes at the lowest cost. That would be ideal. We want a person-centred system that's organised around what patients need. We want the right services, the right person, the right time and the right locations. Easier said than done, but really important. We obviously want to integrate it, and one of the advantages that we have had at Dental Health Services Victoria, and one of the reasons why it's probably worked as a good pilot of the whole value-based healthcare journey, is that we actually can control, it's probably a funny word, but we have control of most of the funding, both from a population health point of view right through to tertiary. So it means that we can move things around in the buckets that exist reasonably well, and that helps and gives us real advantages. And the other really important thing is that we actually have the one data information system for the whole of the state, so we can actually see data right across the whole state of Victoria in the public sector, and that's given us some real advantages. And we need to measure outcomes and costs for every patient, also easier said than done, but really important part of the process. So one of the things we spent a lot of time doing was looking at the why. Why do you do this? Why would we want to change the way we provide oral health care particularly? And this is the fairly standard response you get when you talk to lots of people about value-based healthcare. And when I looked at it and I started talking to people about it, I got absolutely no engagement from our clinicians or our clients. They looked at it and went, yeah, whatever. Because, you go, well, the population, it's growing and it's also ageing. And they go, yeah, duh, we could tell you that. They look at the increasing chronic diseases around the system once again. They know that. They see it every day. There's rapidly evolving technologies that constantly cost extra money but add huge opportunities. Rising consumer expectations. There's really uneven quality and significant variation in health outcomes and health inputs right across the system. And all of these result in increasing costs. And we are all dealing with that. And I can remember when I worked in ACT, I remember the health minister doing a graph of when we'd run out of money, and the whole of the revenue stream for the ACT, I think by about 2030, was meant to go into the health budget alone if we kept going at the rate we were going. And I think I remember that as being quite an important moment in my life of realising we can't keep going the way we're going. So, and we looked at healthcare variation in our setting, because you've probably all seen the multiple health variation slides that you see when you hear about value-based healthcare, but I wanted to do one for dental because we didn't have it. These are not outcomes, they're more inputs, so they're actually services, because we don't have outcomes data yet. But we did it across local government areas so that I wasn't pointing at particular places, and it sort of it wasn't identifying different organisations. And as you can see, this isn't a pleasant thought. And I'm sure you could go into any of your areas and run graphs like this and you get the same sort of data. It'd be different services or different outcome data, but you'll get data like this. And when you've got that much data, that much variation, you've got waste, and you've got people getting low value services, and you've got some people who are not getting enough. And that's all mixed in there. And I think this graph comes out of New South Wales, But it's a really important graph because what it says very clearly around the world, it doesn't matter how much you spend, it doesn't necessarily mean you're going to get better health outcomes. So just pouring money into things is not going to improve health outcomes necessarily. So we need to make sure that when we do invest in health, we do it the right way and we make sure we invest in things that are going to improve health outcomes, and always have that equation in the back of our minds every time we work at it. One of the things we want to do is, we've got a health system out of the way, we know why we should be doing it, it's pretty obvious we're going to run out of money, but the why from the provider's perspective. And so we did a lot of talking to why aren't you engaged by the fact we're going to run out of money, because their view is we'll just get some more, there's plenty of it. And, I've made those sort of comments before as a clinician too, just that's not my problem, administrator, you worry about it. What it was from a provider's point of view is quite a lot of providers get to a certain age when they go, I've been doing the same thing over and over again and I'm not seeing an improvement in health outcomes. I got into this profession because I was going to improve health, I wanted to make a difference, and I'm not seeing it happening, and the system's stopping me doing it, I'm stopping me doing it, it's just not working. And most of them are really engaged with wanting to make a difference. And so they keep seeing waiting lists grow, and particularly in oral health that's the case. Not enough funding, not enough anything. How can we do it better? And so I've found that most clinicians are very engaged. It gets a bit different when they get down to what they have to change about it. That's a different thing. But conceptually, everybody I've ever met from a clinical perspective, and anyone in staff that are in public health, really do want to make a difference, and they're engaged with the why. Now, the most important people along this is the consumer, and we often forget why they want it changed. And so we spent a lot of time talking to consumers, both within our organisation. We went out to lots of people, and one of the things they kept coming back with was, we actually don't really want your services. We actually want to be healthy. We'd prefer not to have to use them if we could. But if we do need to use them, we would much prefer that we are part of the decision-making process. And you quite often don't engage us in this. You keep us out of it, you talk over the top of us, you don't respect us as knowing much about it. And this was a pretty consistent thing. And it doesn't matter what industry you go into, you'll find that's pretty normal. And most people I've spoken to that do the same thing, they get this same sort of message. People want to be respected and be part of the decision making, and often get very frustrated when they find out they're too far gone from with a chronic disease, and if they'd known something before, they would have made a difference. Now, I'm not saying that everybody follows all the prevention things. I know that that's still an issue, but sometimes we need to do a lot more in that space of helping people make the right decisions. So the consumers are pretty on board. In fact, we've got a lot of consumers involved in value-based healthcare at DHSV. They can sit up and give this same presentation, and do quite often. So they're our greatest funders. So the next bit is, where do we start? And I'm going to pass to Sue now, because she's the one doing all the implementation. I just did the easy bit, which is talking about why we got to where we got, but Sue's going to talk about the what we actually did.
So how did we get to where we got to? In a variety of ways, but in short, we started with Porter and Lee's model around value-based healthcare. So both Zoe Wainer, who's in the room, who's our board chair, and Deb, our CEO, went to Harvard Business School, and they went and they learned about the Porter model. They met Elizabeth Teesberg, who actually is probably the driving force behind a lot of this, and actually spoke to her at length about how do you actually implement this in a different culture, in a different country. So we actually developed a model of care that enabled us to figure out how do we do this differently in dentistry. But then we actually looked at it and went, well, that's just about the patient-facing piece. What about all the other pieces of the model that Porter and Lee talk about? So we've actually developed a framework that encompasses all those pieces of the puzzle, but we actually put a few things extra in that we thought were really important. Probably the most important thing is the piece that Deb's talked about, the co-design piece. So we needed to make sure we co-designed A, this framework, and B, our models and any of the things that we're doing with our consumers, but also with our clinicians and our workforce, and making sure that we've brought them on the journey with us. So that's why the consumers and the workforce co-design engagement is smack bang in the middle of our framework. The other pieces of the puzzle, as I said, we've developed a model of care, and I'll talk a little bit more about that shortly. But the culture piece was another huge piece that we thought was really important. If we're going to transform the organisation, which is what we're doing, how do we do that? How do you actually completely change the way that you do things? As Deb talked about, how do we make sure that our senior clinicians are working to the top of their scope? How do we have the conversation about the fact that oral health therapists are going to be doing a lot of the work that they have traditionally done? How do you actually change people's behaviour? So there's a lot of work that we've done around culture and cultural change. We also looked at how do we measure outcomes and how do we measure costs, and we're still working very hard on that. Measuring costs, as we all know in healthcare, is extraordinarily difficult. All sounds very simple, but when you're trying to actually figure out exactly how long things take and how much that does cost you, it's actually quite complicated. Measuring outcomes. So we worked with the International Consortium of Health Outcome Measures and developed an oral health data set. It's currently 23 questions plus a whole stack of clinical tests on top of that, so quite burdensome. But we're using it, we're testing it. It's currently being tested in all sorts of interesting ways at our place at the moment, but we're actually figuring out how do we use that data set, not only to see how people change over time from an outcome point of view, but also how do we use it for clinicians to have conversations with our patients around, so if this is what your outcomes currently are, this is what you look like, what are your goals, how do we actually help you improve those outcomes? So a really important piece of work. Working on a funding model. So we all know that if we don't change the funding model, the incentives to keep doing widgets are highly there. How do we stop doing, we talk about dental weighted activity units in the oral health space. How do we stop talking about DWAR and start talking about outcomes? What does that look like for us? How do we collect all this data in a really efficient way and use the evaluations to make sure that we're actually doing the right thing? The next piece of the puzzle is how do we actually take it and integrate it across the system? How do we put the mouth back in the body? We've been really good in oral health in actually putting dentistry and oral health over here and mainstream health over here. How do we actually put it all back into the same space? But also, how do we integrate this across the whole system here in Victoria? Next piece of the puzzle is how do we actually get IT systems that support that? I remember we've been having this conversation about a new electronic oral health record and that we're all going to be completely digital and paper-free and all that sort of stuff. I started my nursing in 1983 and I got promised that, and I'm still waiting. The other piece of it is infrastructure. How do we make sure that our infrastructure supports a family and a patient-centred model? How do you actually have infrastructure that does that? At the moment, probably not so great. So that's the framework that we've developed. And as I said, we worked with ICHOM. It took us 2 years to develop a data set for oral health. So there's 23 patient-reported outcome measures and some other clinical measures. At the moment, we're looking at what are the patient experience measures that we should be measuring. So what is it? I mean, if you talk to Elizabeth Teesberg from the Value Institute, she will say, instead of saying, how were we, it's more like, how are you? So how do we actually change the way we actually measure experience for our clients and our patients around what is in it for you, what does it look what looks different? So we're in the process of testing that as we speak. As I said, we're developing a new funding model. Really interesting times trying to figure out where all our costs are. Do we actually, at what level do you cost? Do you actually do time-driven, activity-based funding costing? Do you sit there and actually measure how long it takes a dentist to do X, how long it takes an oral health therapist to do Y? We're trying to figure out how we can do that in the simplest way to get the data that we actually need. And conversations that we've had with people all over the world, to what level do you actually cost? Do you actually need to go down to individual level, or can you keep it a little bit higher? Scott Wallace, who's one of the other people who works at the Value Institute, talks about overheads are evil, but everybody on the ground goes, overheads, we'll just worry about them later. Let's figure out what we can actually influence and change. So lots of interesting conversations for us around what that actually looks like. So what's really important, what we've learned over the last, we've been on this journey for probably 3.5, 4 years now. What we have learned so far is that leadership is critical. You actually do need, from the board to people on the ground to your consumers, who's taking the lead to help you do this. Outcome measurement is a team effort. It takes the entire system to measure outcomes, not just a person. Culture will drive success. If your culture is not right and you don't actually have a culture of change and learning, a lot of this is how do you learn along the way. What we've learned is that people revert to type very, very quickly. So if we're not there continuously pushing the boundaries and making sure that people are actually working to their top of scope or actually having appropriate conversations, they'll go back to drilling and filling in a heartbeat. So it's actually really interesting watching that change. The first step is often the hardest. I talk about ripping the Band-Aid off. We've ripped the Band-Aid off. what everybody in this space talks about is that start small. Don't try and boil the ocean. We've kind of tried to boil the ocean a bit. We've taken a few steps back as well. It's really about taking those first steps. Start measuring something, having a look at what you can actually measure. And co-creation with consumers needs skills and practice. We've done a lot of work co-creating all of the pieces of work that you've seen here tonight, but having our clinicians have conversations about co-design and care plans is a whole new skill that they haven't used for a long time. They might have got taught it way back in school, but haven't really used it because they've been on the merry-go-round of let's get stuff done. So completely different skill set that people need, and we're actually training people and retraining people on how to have those conversations. So some of the things that we've achieved so far is that we've actually decreased our failure to attend. So our current failure to attend rate in general clinic runs around 18-19%. What we actually now do is run what we call an introductory session or an induction session, depending on which day of the week we talk about it. Language is a really interesting thing. We've changed it. We've gone to clients, not patients, because we're talking about a wellness model, but then the clinicians have reminded me, Sue, yeah, but we have a therapeutic relationship with these people, so they are patients. We actually have this induction session, which is a group session. We bring a group of people together and actually have conversations about what they can do to improve their health. The fallout rate of that's about 18%, but once they've been through that session, our actual failure to attend rate in clinics dropped to around about 4.5%. So massive change. We've increased the things that the dentists are practising to the top of their scope, so they're actually doing work that only the dentists can do rather than work that other members of the team can do. We're doing a lot more preventative interventions rather than actual surgical interventions, which is a really important part of this puzzle. We've got really strong patient co-design, so they're co-designing a lot of this stuff. We're learning every day about what's different and what we should do differently, and we're getting great satisfaction from them about them being on the journey with us. And we've got strong clinician engagement in the small group of people that are actually working. They're working as a very tight team. So currently in dentistry, we often put the dentists over here and the therapists over there and the admin people over here. We've actually put them together as a team, trained them as a team. They've all learned the same things, and they're actually an extraordinarily cohesive team. They've learned how to problem solve together. They've actually learned how to work together in a much better way. And the consumers are actually seeing that and telling us that, which is great.